All right, well, sorry for the delay. I noticed we do have a couple of people online, so feel free to use the chat for questions as they come up. But my name is Jonathan Bushman, DO, Rebecca Lewis, DO, and we really just want this to be more of a roundtable type discussion, Q&A, almost a mini mentoring session for anyone who would like. So with that, I'll let you all get started with questions and let's take the discussion there. Yeah, so my background is I am almost 9 years out of residency. It's hard to believe, but 5.5 years of that was under one employer, but under 2 different contracts with that employer. And then I have been independent for the last almost 3.5 years. And my only contracts I'm really dealing with there are with employers. So completely different than contract negotiations as an employee position for sure.
So I'm Enid, and I do obstetrics as well. I am currently in my 8th year of practice, and my first 5 years were with one employer, one contract within that. I did sign that contract as a first-year resident, so I've got a lot of little snafus that I wish I had known more about. And then currently in a similar contract model with a different employer.
Very good. Well, if you have questions, I want to step off the screen for a moment so you guys can say it into the mic.
Sorry, it's awkward with just 4 of us on the microphone, but for the Zoom link, so.
That makes sense. We have a question. So if you are a resident early on in your residency and you are very interested in direct primary care models and independence models, and you're trying to look at a lot of the rural Oklahoma benefits for providers with longer payment, you still accept Medicare and Medicaid contracts. Can you speak to which one is more financially viable?
So I think everyone was able to hear the question online as well. I would say I know this answer probably more clearly because I've done both. So coming straight out of residency, I'm going to back up a little bit deeper than your question for a moment. So coming out of residency, I think something that is a really common, I wouldn't say it's a mistake, it's just a common situation, is that you've been essentially either unemployed or partially employed or employed through residency for a total of at least 11 years, right? So we haven't been working jobs for wages. And if we have, they've been wages to barely pay the bills or just a part-time supplement. Very few students have been full-time and specifically full-time professional making a 6-figure salary. So you go from, I've given up 10, 12 years of my life to pursue a profession that's going to reward me for this. And you're at the end of that going, okay, now what? It's really hard to give up the lure of a guaranteed salary, especially in the numbers that they give you, almost regardless of which field you're going into, versus saying, you know, I'd like to go hang my shingle. I'd like to keep my expenses low. That's a tough psychological ask, but I also think it's a really tough psychological situation to be deprived of sorts for so long, and you've delayed the gratification, and now it's like, I deserve this. I deserve this. And so going into those contracts, and I will get to your question, I promise. Going into those contracts, then you're overpaid for probably the first 1.5 years or 2, period. Like those guaranteed salaries, you are not going to be producing the amount of revenue through that contract to justify in any real sense, in any real business sense, the money that they're paying you. By the time you get into a typical 3-year contract, by that 3rd year, you might be producing that much, but now you've got this deficit that you've got to crawl out of before the employer may justify increasing your contractual terms, right? And so again, psychologically, you feel like you're making incredible money in the beginning, and then you're working harder, and yet that income part doesn't necessarily go up in accordance with the work that you're doing. And I think that's why you see a lot of folks get into early contracts. They last 3 to 5 years in their employment, and then they go do something different. They either move to the other hospital in town, or they move communities. Like I told you, I was 5.5 years in before I made my move. I was 4.5 years in before I decided to make my move. It just took me a year to get to where I needed to be to do it. Now to your question, can it be done, and how do you do that in a sustainable financial way? Number one, and most importantly, I think I failed, and I see it happening with a lot of students and residents where we don't know how much we need. So if we can start with the basics and say, okay, I have a $1,200 house payment, or I have whatever the house payment is, I have the car payment, I have these specific known fixed expenses in my household. I know this, right? And with that, there's a basis for what you need and what you need to survive. And I realize what I just said, you spend a decade of your life getting to the point where you shouldn't have to worry about survival. Yet, if you want to be independent, you may have to think like that a little bit. Okay, if I can live on $60,000 a year as a resident, can I do that as a first-year physician? The answer is yes, absolutely. And different than 20 years ago, when you had to purchase your own EHR and computer systems weren't cheap, and you had to hire IT firms to come in and actually network, where now you can do it on your own. I mean, most of the things that we think on technology terms have simplified in a lot of different ways, specifically software as a solution. So if I can do a cloud-based service that I pay a fee for per month, I can keep my expenses down. If I can pay a flat rate on billing, I know what I have. In my billing world in DPC, I pay Stripe fees, okay? It's credit card fees, that's it. I have ACH fees for banks, and I know what those are, and they pale in comparison to true billing fees. My billing fees that I pay, the company I work with for billing for the fee for service that we do have, is 5% of collections. So their incentive is to collect the money, and it must be that way. You hire a biller internally, they've got a job. Yeah, they need to collect, but they've got a job. So the incentivized percentage of collections is a good thing. Going into a Medicaid and Medicare contract, if you did that in addition to DPC, like a hybrid model, you're going to build quicker, but you're going to have delayed payments. So between credentialing on your own, if you don't do it through a health system, anticipate 6 months for credentialing. And if it takes 6 months for credentialing, keep in mind it's going to take an additional 60 to 90 days before the first bill is paid after you're credentialed, because they see you as a new provider. They've got to make sure they've gone all through those credentials before you're paid. So there's a major delay in payment as a new physician. And that's another barrier coming out of residency that you just have to anticipate like a year ahead of time. Yeah, this conversation with another physician this weekend, but talking about a hybrid versus, would I do anything for service? Would I do partial direct primary care? What would I do? And I think our lecture yesterday was pretty good about just specifically different value-based payment models and prospective payments. So now with Medicare ACO REACH models, you could go in and know, I'm going to get this much per month, gives you some cash flow, so you're not hanging on to or borrowing a bunch of money to get started. And I think independence is now a much more viable option than it once was, because, like I mentioned, start a clinic for $31,000 is pretty cheap. Okay, now you have monthly expenses, you have staff, you have utilities, you have EHR, you have insurance. You have a lot of different ongoing monthly expenses, but you don't have to go out and ask the bank for $250,000 on top of your $300,000 in student loans. So
I think another part of that question was the rural repayment programs like PMTC. So my understanding, the way the programs are currently, you may know otherwise being on the PMTC board, but you do have to have buy-in from the community. So it doesn't necessarily have to be the hospital system, but the last year of your PMTC program, a certain amount of that has to come from the community that's sponsoring you. The first community that I worked with, they actually had a community health advisory board that was made of multiple different entities, the hospital, the nursing home, others, people who've invested into the physician community. So I think if you found a community like that who had a board of that kind with the finances to sponsor that last year, then I do think that you'd be able to do a DPC type model without having the hospital backing. But like I don't know of anything in we're both in Enid right now. I don't know of any, maybe Northwest we have like somebody, you might find somebody who'd be willing to sponsor and meet the PMTC requirement, but you really just have to research that community pretty well and find out what resources they have. But I do think that it would be doable to not have to go into an employed model if that's not what you want to do. So, now, the one thing I will say, I think PMTC is a great program. I'm a PMTC recipient, so is Dr. Bushman. So it's a phenomenal program, especially the program that they have now. I was one, I think you probably were too. We only got the small program. And once you apply for one, you couldn't apply for a second. So now you can apply for both, which not better. But one thing to remember when you're signing those things, whether it's PMTC or early like loan stipend while you're a resident, people will come to you with some very enticing things. And I do think this is one of the biggest pitfalls that you can run into as a resident is signing on to something because they made all these promises. Again, PMTC is great. I would sign up for PMTC again 100%, but some of the hospital promises, they can come to you and say, we're going to give you all of these things, and they may follow through with it, but as an incoming resident or as a new resident, you don't understand your value. And I think that's the biggest pitfall as a resident you fall into. Like Dr. Bushman said, you've lived in this deficit for so long, and med school, residency, you're in this habit of, I have to sell myself to them. When you start going on job interviews, you don't realize it yet. They're trying to sell themselves to you. Every hospital, there are not enough of us out there. They want you, they need you. And so they are trying to sell themselves to you. So they will give you your offer. Just know it is not the final offer. Every offer is completely negotiable. So for me, I think the two biggest pitfalls I ran into were signing so early without a lot of knowledge of what I was signing on. But again, it's like, oh my God, somebody wants to take me as a job. I'm going to give you all. Yeah, please take me. So there was that, but then also not using a contract lawyer. Use a contract lawyer. It is inexpensive. It was now, but it's about $500 the last time I checked just to get a basic contract review. They're looking at hundreds of contracts all the time. They understand what other people are offering and what you can negotiate and what you can't. I'm pretty sure my very first contract, I left a lot on the table. And then to find out later that other people that were coming in were being offered more, higher, bigger differences and everything there. It's something, just don't let yourself get too excited about the first offer that anybody gives you.
Check online. So yes, I serve with Dr. Carter on PMTC as well as Lane Sabera from SkyTook. We're the 3 DOs on that board currently. And the rules under PMTC state that you have to have a Medicare and Medicaid contract. That is not statute. And the reason that was written that way, or the rules written that way about 30, 40 years ago, is because originally those monies went through the OHCA, and the checks were cut by the OHCA because they were kind of a financial partner, if you will, of PMTC and getting people placed. That's no longer the case, and I have raised that concern that can we not still be treating or taking care of the underserved or underinsured or populations that need people? It's still a huge value, and that's not a statement against Medicare or Medicaid that you wouldn't be able to do it, but the qualifications and the rules Statute trumps rules every day. So rules are created to try to have something to go by within the commission. And I'm asking those questions because I think and this is the point I made at our strategic planning. I believe that if you've put in that much time and effort for your career and you've decided where you want to go and you've decided that you want to hang your own shingle and work, and that's your motivation and that's your livelihood and that's your career, and there's a program to help you get started and get on your feet to do exactly what you want to do, I think that's the mission of putting people in rural America, rural Oklahoma in this case. So I don't think there should be a barrier to it. Now, could somebody manipulate or use that and it become a bad situation? Probably could, because at least under Medicare and Medicaid, they could track numbers where if you're not on the grid, so to speak, in the billing world, it's harder to track the data to see that you're working. So that's one of the administrative concerns.
That was going to be my follow-up, specifically the question of, and Dr. Cook phrased it well yesterday about the I think it's Medicaid requirement. The auditor comes in and tells them to change the lights, and that's obviously going to cost money to maintain that contract. And so then it becomes a question of, is the $50,000 after each year, so it ends up being worth less than $50,000 a year, is that worth more than the maintenance of the contract? And I don't know how to answer that question because I don't know.
So I have a Medicaid contract for our clinic with one specific provider, a PA in my clinic, and that's possible too. Honestly, only a couple of the commercial insurances make you have a universal contract with your tax ID. Medicare gives you the option to have a group NPI, same as Medicaid, and you can be credentialed, but you can credential individuals, and the billing is done through the individuals. So if you have partners or you're in together where one person wants to take Medicaid, one person wants to take Medicare, and the opposite is not true, you could have one provider credentialed with Medicaid, one provider credentialed with Medicare, and serve those populations all in the same business. So that's interesting. But having had that contract for now over 3 years, I've never heard the light thing. I don't know about that, but I do have LEDs. So I converted all those on my own without someone asking. But I can tell you that as far as the payments right now under fee-for-service Medicaid, they give basically patient-centered medical home has 3 tiers, depending on how much you guarantee in terms of availability. And specifically the highest tier to get paid the most on a very small capitation is that you have to provide some evening or weekend hours in the clinic. We're in the middle tier. We don't do the weekend or evening hours, but we're in the middle tier, and I don't know, it's $7, $8 a month per member that Medicaid will monthly send our way for our panel, and then it's fee-for-service on top of that. From Dr. Pastor's lecture yesterday, if you saw the spectrum of everything from fee-for-service to complete population-based payment, toward the end of that was a capitated plus, right? And right now, the patient-centered medical home within Medicaid is kind of like a capitated plus fee-for-service. So you're getting a little capitation and then mostly fee-for-service. If that were flipped, it would be much nicer from prospective payments, and there would be a lot less unnecessary care and billing, and probably be able to serve a bigger population because you weren't doing certain unnecessary time-consuming tasks to bill Medicaid. And I think they're getting there. I've actually had chances to speak to both Oklahoma Health Choice and OHCA about these, specifically EPC, the models that pay more toward that capitated or population-based, and they're looking at it. They realize that that's where everything's headed, even with the Medicaid expansion and the bill that we're facing right now. Ideally, they're going to function more like that. Problem is the third party Anybody online have questions? I'm going to check the chat again.
One thing I think that would be helpful for you guys to
What kind of questions should we be asking regarding RVUs in an employed position?
that was actually what I was going to talk about. So there's a few things that are really helpful to fully understand as you go into, because these are things you're not taught in residency, because your RVUs are going to your attendings and all that. So both of my contracts have been very similar. I think Dr. Bushman's was similar but different because you guys had a rolling quarter. Okay? Yeah. So my contract is a true salary with an incentive base is what they pretty much call it. So I have my base salary and then I have my incentive on top of it, and that's for my production. So my base salary, I get a paycheck every 2 weeks. It's the exact same amount every time. My insurance coming out of it, my benefits coming out of it. And then my quarterly, I get productivity bonuses, which sometimes gets frustrating when they call it a bonus because you did work for that money. And so it's really a true up to what you had done. So you get your productivity payment every quarter. With that, you'll get a dollar amount that's assigned to you for your RVU. And so what an RVU is it's assigned by Medicare and by CMS, and your relative work value unit, it is a dollar amount that they pay, or a number of units that each thing gets assigned to. So you've got your billing codes, your 9921, 321, 4215. Each one has a different percentage assigned to it. A delivery, so average clinic one's between 1 and 1.5. My deliveries, when I do prenatal care plus deliveries, it's about 34 to 40, depending on C-section or vaginal. Different procedures will have different values assigned to them. So then your hospital or your contract, if you're in an employed setting, they will give you, this is the dollars that you make per RVU. So that recently has gone up for family physicians. We're expected to be making closer to the 52 to 54 mark. Not all hospitals are paying into that range yet. So I've seen some contracts where they're offering as low as 25, and I've seen some where they're offering the full 54. So, which that's something that you need to know. There is something called MGMA data, which is very valuable information to get if you're going through an employed setting. And that will give you what the median data is for a physician, what specialty, what location, what services, and they can tell you exactly the median data for this region is this amount of money. This is truly what you should be targeting. And most places will pay you at the 75th percentile of the MGMA. So it's pretty important information to have there. That information also can include what the median RVU payment is for that. And so for me, I get, so my salary, whatever the base is for the quarter, I have to meet so many RVUs, and then any RVU that I exceed over that, then I get my payment per RVU as a quarterly payment. And so for me, it's nice if I've got my secure, here's my base salary, but then I also know on average what I bonus each quarter, and if I do more deliveries or less deliveries or whatever, I'm still secure in what I'm doing. Some of the hospitals do more, and mine is the same every quarter. This is my payment, my contract across my contract. There is no fluctuation. Some chains do a little differently. That's what you want to do.
So I actually started as a collections contract, complete cash collections contract, which was a fairly popular form through the 2000s and most of the 2000 teens, early-ish anyway. And then they converted me to RVU. As I mentioned, at the 4.5 year mark, that's when I decided to go. But it's the frustrating thing that, well, the reason Medicare did that was because they wanted to say we've got to create some semblance of a value for each service rather than just attributing a dollar amount for each and every service. If we can just come up with what one unit the basis is, then we can make a conversion with this RVU, right? So it was trying to simplify pay. Unfortunately, when they sort of blinded, in a sense, the cash collections specifically from employed physicians, and it comes in the form of an RVU, now there's that conversion factor. And like you said, it ranges so widely. You don't really know if this is good or bad, and that's tough. Transparency is absolutely key to me, and that was kind of the concerns I had was the lack of transparency, but also that my work at that point for me, and this is just personal, but at that point for me, it minimized it to this unit-based. I'm counting units. I got to do anything to count these units, and so I felt like at that point my incentives and motivations just were not as pure as they could be or once were. And something that I had recognized through 2 different contracts is that my first contract, I had my base salary and I knew what it was. And when I started bonusing, I was very fortunate. I had a mid-level provider that left the practice, and instead of hiring another mid-level in a physician at the time, I acquired the nurse, acquired the patients, acquired the revenue, right? So my work went up a lot overnight, but I immediately started getting into this productivity bonus. The following year, they offered to increase my base on my salary, and I said, thank you, but no. So it was, again, that's psychological, but I'm like, no, I don't want any added basis, because then when I get a productivity bonus, it truly feels like a bonus. When they changed the contract later on, what they said was, here's what your total annual pay was last year. We're going to give you 88% of that up front, and then through quality bonuses, you can make 12% back. 12% of 88 doesn't equal 100, but anyway, you can make 12% back, right? Now I feel like my productivity is almost like a burden. So now I have to maintain that productivity in order to not get a cut on my paycheck, right? And that was frustrating, because I'm like, I wanted the ability to pull back if I wanted to, but they'd already created the base to go to where I had been producing. So that to me was a pitfall that I had tried to avoid in one case, and then later it was just told to me, this is what we're going to do. But if you have the chance, and this is what I've done in my private practice, going back to my previous answer on, I had to find out what's the least I can live on. I literally created this paycheck to paycheck program within my household. This is what I have to live by to make this work. And I still do that. So the nice thing is I'm no longer in that position, but I can be. That's where I've set my lifestyle up, so that if I need to have monies in other places or invest or whatever, I haven't already attributed. When you get that base, and I'm telling you, it's weird, but if you go through your entire 20s without any money, and then all of a sudden every 2 weeks you have, multiple thousands hitting your bank account, and you only have about 30% of it to spend, you don't budget well. It's tough. It's really tough, because it's like there's all this money sitting there. So you either got to move the money quickly to get it out of sight, or already predetermine where it's going to go, and in the same time avoid making decisions that are going to cost you for a long term. And I think that's where, in general, most financial advisors will tell you physicians are absolutely some of their worst clients because of that, of the money management.
One contract model that one of my friends is in right now, she works for another employer, and she's on a rolling quarterly RVU repayment. She does not love it. And I will tell you that's part of the reason she's not here this weekend, is because she's having to make up RVUs because of timeout from her father-in-law passing. So rather than allowing her to appropriately use PTO and things like that, then she really is kind of in a pitfall with that. And then also our physicians who go on maternity leave with the system tend to really struggle when they come back on, because the way that hers works is they look at her previous quarter and say your RVU production was at the 50% MGMA data, so we're going to pay you this much per RVU. And so that's what she gets paid for the whole next quarter. If her RVU average that next quarter goes up to the 75th percentile, then they pay her more for the next quarter. So it's this constant drive within that system that you don't feel like you can ever pull back. You can't say, my family needs me more right now, I need to step back, because you're gonna take a huge pay cut for doing the same amount of work. And it's very unique system, but unfortunately it's one that we're seeing a lot of. It protects the employer. I understand their desire to use that, but it is not physician friendly necessarily. If you're always one of those 75 to 90% producers, then you are doing phenomenal with it. But when you're getting started, when your family events happen and life happens, it really can take you from making up here to just all of a sudden making down here, and not really noticing that shift as much in how you're able to work on the day-to-day or anything along those lines. So it's one that, fully understanding how the RVU model works for the employers that you're speaking to is vital. Dr. Bushman also mentioned the quality performance and the reimbursements for that. The knowing how they reimburse for their quality markers and how they get that data is also very important. My first year in my new practice, I actually did not do great on my quality markers, not because my patients weren't getting quality care or having that quality work done. I wasn't checking the right box. And because I didn't check the right box in my EMR, my data didn't count. And so I left a lot of money on the table because I did not check the check marks in the EMR. And so that is something that if you are going the employed model route, having a full understanding and talking to them even in this contract negotiation process, how are your RVUs reimbursed? How are your physicians? And talk to some of the physicians. If you can talk to them one-on-one without any administrators there, they can tell you, hey, these are some of our pros and cons. These are some of the things I wish I'd done differently. And a lot of times doctors are pretty candid with each other when there's no administrators nearby, even if they're trying to recruit you into their system, because they want to see you come into the system, because they need help and they want good colleagues and everything, but they also want to make sure that we protect each other and try to make sure that, hey, I didn't do this, but I do plan to ask for this on my next contract, and you should ask for this on yours too. So.
Any other questions online, feel free to type them in. We'll get to them.
Like the contracts.
So length of contracts are another important thing to know. They're all going to come to you with a request for like a 3 to 5 year contract, because they're going to want to lock you in and know that they've got, longevity within the contract. Just know that you can request a shorter contract. So that's another thing. Again, this is where contract lawyer comes in really helpful. Also, make sure you always just kind of look at your non-competes in your contract. Non-competes are not legal in the state of Oklahoma. Yeah. So, and they will. So it's very helpful in contract negotiations to say, these aren't legal in the state of Oklahoma. I'd like to see this removed, or I would like to increase or decrease the zone that you're listing here, or do whatever. Even though I don't plan to use this, I still don't plan to sign a contract with one in it. The other thing is just knowing what your out clause is, because I'll tell you, most of the contracts that I have seen, I have a 90-day notice. That's all I have to give on either side, though. So it does work both ways. They could give you a 90-day notice and say, in 90 days you don't have a job, so start looking. Same time, though.
I've got one quick point to make on that. My first contract had a 90-day termination clause that guaranteed me pay unless they specifically told me I do not want to go, or I specifically told them I'm leaving early and I wouldn't get paid at that point. So long as I finish out the 90 days, or they asked me to leave prior to the end of the 90 days, then I was still guaranteed those 90 days of pay. On the contract renewal, they left that clause out. So it was the 11th hour before I signed that contract, after I asked multiple times if it was if it was negotiable, and they wouldn't give me an answer. And I finally said, I guess I won't sign. I mean, I can't sign this. And they said, well, what would you want? And I said, put that clause back in there. And I was pretty bold to say, like, I'm not going to be here for much longer. I just want to make sure in the event that I resign, that I'm not just walk out the door and not paid for the next 90 days. So that was a very, very specific and could have been a costly error had I missed it.
You got someone here. You got some questions? Yeah. Did you already do? Huh? Oh, it was, what kind of questions should I be asking regarding RVUs in an employed position?
If you could follow up, the person that asked that question, can you follow up and did we answer the question to your liking, or is there something more you were kind of looking for on the RVU basis? And I would absolutely tell you, I know she mentioned contract lawyer, but if you're thinking of independence, your lawyer is obviously a first really good key to setting it up, because you're going to need articles of incorporation, you're going to have an operating agreement, you're going to have you're going to have to establish the entity with the Secretary of State, you're going to have to get the tax ID number. Lawyers can do all of that for you. They can do parts of it for you. You need an accountant, but you need someone who understands healthcare accounting. You don't need to do that on your own. That's tough. You need a credentialer who knows what they're doing, who can advise you on that stuff, because credentialing is not limited to a hospital. It's not limited to an insurance company. So credentialing, you've got to change your NPI. You've got to make sure that the system recognizes who you are and that you have the proper taxonomy in the event you're doing anything. This wasn't shared in yesterday's lecture, but there's a little part of me that I'm board certified again through family medicine OMT. I've been practicing DPC over 3 years. What if I wanted to go back to a managed care contract? Would I be allowed in, or are they going to look at me like, you haven't been on the radar for a while? I'm not really worried about that at all, because my credentials, I think, will speak for themselves in terms of board certification and such. And I've never been terminated from an insurance contract. I've always voluntarily withdrawn my credentials from them. Something to bear in mind there too.
One other thing, just because you mentioned kind of some of the financial stability as you're starting in DPC and everything as you're coming out of practice. One thing I've seen several of my friends who are in DPC straight out of residency do is actually have like a part-time job with one of like the urgent cares to kind of have that steady income while they're building that DPC practice, because it's one that they could easily and flexibly do. I'm not sure what your thoughts on that are, but I think that's what I've seen with a lot of DPC people is doing that. Maintaining also is a good source to get patients while you're in the theater, when you're in the urgent cares. But that's another way that I've seen a lot of people kind of try to manage that balance as they're getting started. Again, having a great contract lawyer to help with that, to make sure you're getting appropriate hourly wages for that. And again, I think, the biggest thing I can drive home to any resident who's trying to figure out this whole new process is just know that you are worth so much more than what you think you are. There's kind of that imposter syndrome going from resident to attending of, oh my gosh, I'm just a first year in practice. No, you are a first year physician in practice, and you have got so much tremendous value to the system, and just know that you deserve to be paid what you should be, because you are going to make it out here with that.
I think those are great points, and I will tell you too, like, I again personally believe if you've gone through college, medical school, postgraduate training, and you determine that this amount of money right here, even if it's half of what my colleagues are being paid, is adequate for me, it allows the lifestyle that I want, and I'm completely satisfied with this, you should have the ability to do that. I even think you should have the ability to do that in an employed setting, but you have to have the conversation with them to be able to say, look, I know you offer this guarantee of such and such. Would you be willing to guarantee me 60% of that? And this is how I'd like to work. And I know that the reception based on the generation of who you're talking to may not be the same, but most administrators and employed health systems understand that the next generation of physicians are looking for that work-life balance. And if we can't get our contracts to reflect that desire, we're not going to keep them for the long term. And again, as Dr. Lewis said, use that to your advantage because you're worth it, okay? And your family's worth it, your lifestyle's worth it, all of those things are definitely worth it. And then if you find that you just really enjoy working a lot, you want to be busy and those production incentives really, really work for you, great, do it. Yeah, if that's what you want, do it. If that's what sustains you, do it. Just be careful not to put yourself in the place of need, where this is the only way I can survive, because it doesn't matter how much money you're making, then you won't be happy. And that's personal experience. Good deal. Any other questions online?
No, sir.
All right. Thank you, guys.
Other things I just thought of to make sure you talk about your contracts too. One is who hires and fires your paper, or hires and fires your staff, because that's huge. And what are they going to do? Like, how will they ramp up your staff as your practice grows?
So they can.
Oh, sorry.
Oh, no, that's fine. You can just keep
Oh,
talking. Yeah, they're still on.
Okay, I was telling them a few things I just thought of also is making sure you know on staffing who's going to be responsible for hiring and firing your staff, and how they plan on increasing your staff as your practice grows. So in my first practice, I was up to almost 30 patients a day, still with one nurse, watching the nurse practitioners that were in the same system as me, with two nurses seeing half of what I was seeing. And they kept saying, well, we didn't plan on hiring a second nurse for you until you've been here for 6 months. I said, okay, I know it's fine. I've been here only for 6 weeks, but I'm seeing 30 patients a day almost. I mean, I have 28 patients on my schedule this morning. I was having to do like nebulizers. Well, there were other patients in the room because the nurse was still running a patient. So knowing how that's going to be done is a really important thing. Your administrative time is another really important thing to contract in there. So a lot of physicians go in thinking that they have to do 40 hours of patient-facing hours, but most contracts and most facilities will let you do a good half day to a whole day of administrative time. Because you've got that paperwork, you've got those FMLA forms, you've got all that stuff, the prior authorizations that have to be done at some point in time. So knowing how they're going to give you protected time to do that paperwork so it doesn't become what we call pajama time is something you want to make sure you get that taken care of too. So another really important thing with that.
This feels weird. I don't usually get in front of people and talk, especially with a microphone. Yeah, you have your water. This is real informal, things like that. I have the microphone because so that y'all can hear with us. But my name is Audrey Hendricks. I'm the Deputy Executive Director, Director of CME Programs and Facilities, and the Foundation Administrator here at the Oklahoma Osteopathic Association. I just need one more title, just one. Now, so what I do is I coordinate, I'm going to give you a brief background. What I do is I coordinate these seminars from start to finish. So I coordinate with our program chairs and with their themes and things like that. I am not that creative to think of what's next, announce prevention, COVID, and with all the acronyms, welcome back, y'all, things like that. That is not from this noggin. It is actually from our chairs. And so with that, we find the speakers, and then we do the contracts with the hotels, and then the food and everything. But also, I make sure that we are within AOA guidelines. The AOA has a set of policies and procedures that we have to maintain to maintain our accreditation. And we are, the Oklahoma Osteopathic Association is actually one of 3 AOA accredited associations. There's the OFF, the Osteopathic Founders Foundation. There is OSU alumni, and then there's us. So we are 3 in the state. So for CME in future or present, if you need AOA Category 1 credits or osteopathic credits, it has to say it. This, because it is a disclaimer for all CMEs that you attend. This is accredited by ACCME for how X amount of AMA PRA hours. It has to say also up to 27.5 hours of AOA Category 1A credits. And if they don't say that, look at the agenda. Because per policy, it used to be with the AOA, and this is just, you can find this on the AOA, osteopathic.org, under CME, and then CME policies. But you look at the agenda. If they have the agenda, you look at it, and back in the past, the policy to make it osteopathic accredited was 50%. Well, we always did 50% plus 1 because we always wanted to be certain. Well, now they changed it to 30%, but I still don't like that because I am biased with the osteopathic profession. And so I still maintain that 50% plus 1. So look at your agenda. If you see a DO after that, then you know that that's an hour or however long at the agenda, the speakers. And then some of it also say, Christi here, she is, or I'm sorry, my brother-in-law, for instance, Randy Aldrich. He is an EDD, he is Director of Education. He works at Virginia College of Osteopathic Medicine. So he is a faculty of an osteopathic medical school. So he actually still is considered a 1A credit because he is, and it says in the policy, and you'll see it in the in our accredited requirements, the AOA accredited sponsor, it says osteopathic physician or physician or yes, there's an actual name for it, but then it says College of Osteopathic Medicine faculty. So it can be an MD, it can be a PhD, an EDD, a PharmD. They are still good. So don't be discouraged by that. However, so there are different categories of AOA credit. There's category 1A and there's category 1B. 1A is live, on demand, how we are now, come back and watch this later, things of that nature. And then there's also other areas. And then 1B is like journals and things like that. Those are all osteopathic related education. Now, category 2 is allopathic accreditation. And say it's the AMA PRA, ACCME, AAFP, things of that nature. So you can go onto the CME and you can upload it onto your AOA profile as category 2, because to maintain board certification, you have both category 1 and category 2. Okay. So, and then another thing is, and this is to give you all peace of mind, so you're not chasing down whoever did your accreditation. So per AOA guidelines, the accreditors have to upload your hours. It is not a self-report like category 2s. That is part of our policy per the AOA that we upload your hours. But whenever, for instance, you attend OSU, you attend Spring Fling, you attend a staff symposium, you attend somebody from a different osteopathic state, and you call me and, hey, can you check to see, because I can go on the back end and check your hours. However, I can only see the ones I upload. So it's only Oklahoma Osteopathic Association hours that I can see. But by golly, I'll check, and I'll get you to the right phone numbers that you need to call to check. But we'll also maintain it in our database, because we also have that, you will see it will be uploaded into the AOA and OOA database, because I'll report it to the AOA, and then I'll stick it into your membership profile. So whenever it comes time for licensure renewal, then you can go onto your profile and print out your statement of credit. Now, per the licensure board, you are state mandated to do 1 hour of proper prescribing every year. It used to be every other year, now it's every year. We do an audit system, and this is why I will ask, give me 2 weeks to do the audit, because we need 2 signatures and an attestation form. First signature is your registration, whether it's via Zoom. We actually pull a report on Zoom and we marry them with your email addresses, and then I can kind of pick and choose. Okay, oh yeah, I know, I can get that one. And so that is qualified as your signing in. Now, whenever you're in person, that is the signature whenever you first pick up your registration packet. That's signature 1. Signature 2 is the proper prescribing. That is your proper prescribing. So those are the 2 signatures I mainly look at. Risk management, they will ask for a signature for credit for their premium discounts, because we are one of those that we give you 6% premium discount on Plyco and MedPro for attending our risk management. That is an agreement we have, and that's why it will always be a 2-hour lecture, because that is part of the agreement. But we won't look for that signature. That just goes straight to them. And then your attestation form, which you attest your hours. I attended X amount of hours, print, sign, date. And then we'll ask a couple more questions, like you want to be a speaker. We are always looking for speakers. We are looking for speakers. We do $300 honorarium, $300 off membership discount, complimentary registration, or if you really want to be nice, you can donate it back to the OOA, to another area. Sure. So my sister is also in the audience, who spoke this morning at Informed Consent, Stephanie Aldred, and Dr. Stephanie Aldred, and she is also doing the outpatient here in a little bit at 3:30 of Let Them Play. But y'all are going to be tuned in here. So, because we have one too. But so whenever I do the audit, if you attest to the maximum amount of hours, and we are a honor system, this is a pure integrity check. So be honest, but we will not come hunt you down and be like, okay, check. But whenever you do, and you attest to the full amount of hours, I will look for that signature at the proper prescribing. And if you attested, but I don't see a signature, whether on the job form if you're online or physical, I cannot. I legally cannot upload your hours, because you did not fulfill the obligations and the requirements, or pay. If you pay for registration, I mean, you got to pay to play. But we will let you know. And so whenever you're there and be like, hey, I don't see my hours, but I know I attended. So we go back to that audit and be like, oh, hey, it shows that you didn't do the proper prescribing. Did you do it? Be honest, did you do it? Yes, no, okay. Yes, okay, please sign. No, okay, please fill out another attestation form with that no more than 16 hours if it's a maximum of 17. If you ask, can you do it for me? I cannot. I cannot do it for you. I wish I could to make your life easier, but it is illegal for me to. I cannot do it because then if you say, oh, I only have 16 hours, but I have 17, well, Audrey changed them. Yeah, I don't want to get in trouble. Not really. Plus, that's also detrimental to the OOA. So not only are you messing with my job, but also the accreditation of the OOA. So then I'll upload your hours and statement, then we'll upload it to the AOA, OOA, call it a day. So, hey, I like that. But if you have questions regarding, 1A, 1A, 1B, things like that, to renew your, and I'm segueing over to Christi now, for licensure renewal, you need 16 category 1, not 1A, 1B, category 1. It can be either one. Category 1 credits to include proper prescribing. So what we do as a benefit at the OOA is our summer and winter seminars. We do, again, the requirements plus 1. We do 17, so 16 plus 1. So we always try to do that 1 extra %. It's kind of like Office Space, that flair. You always, you can have the regular amount of flair, but you can have that little extra flair. We're that extra flair. We're, what is it in waiting? Office, 15 pieces of flair, but also, the difference between customer service and excellent service is just that little bit. Well, we do that little bit, or we try to do that. But we also, for your, back to the AOA, sorry, you can tell I didn't prepare for this. I'm just speaking off the cuff. But for your board certification, the AOA has a 3-year cycle. And so we just started a new cycle, 22 to 24, 22, 23, 24. I'm like, wait a minute, 2 to 4, that's 2 years now, 22, 23, 24. It's a 3-year cycle, and that is for your board recertification or certification. And you have to have like a maximum amount of hours, 150 for family practice or 120 for family medicine and then internal medicine and so on and so on. So in that 3-year cycle, that started whenever the AOA had their membership and everything for the board certification in that cycle. But now they decoupled for the especially colleges, and so they are just facilitators to help you out. But that's within those cycles to keep you in the loop of we need this amount to maintain our board certification. But do y'all have any questions? I will stop talking, and do y'all have any questions?
What is the deal with the A and B? Because if I remember right, there needs to be a certain number of A's, but where do B's fit in?
So B's and A's, so the question is for category 1A and category 1B. I'm also looking to see if we have any questions from everybody else too. Where are they? There we go. Q&A? Nope. Okay, we're good. So here, I will scroll down some more. So these are all considered 1As. Formal osteopathic CMEs, grand rounds, on demands, things like this. All of this is considered 1A. And then 1B, oh, here's more 1A. So anything and everything is 1A. 1A, 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 1A. And again, we will make this available on the CME website as well. And then here is the 1B, the certifications, the OCCs, exams, fellowships, GMEs, things of that nature. So each board certification will have how many 1As, how many 1Bs, how many 2As can I have, How many 2Bs can I have? It's all up to your board certification. So make sure whenever you do get recertified at the beginning of the cycle, go to the AOA and check, because these things change every cycle. And the policies will change every cycle. Because whenever I first started here, online, on-demand CMEs were Category 1Bs. And you had to have so many Category 1As, kept so many, like, for instance, I'm just spitting out numbers, 30 Category 1As and 2 or 3 Category 1Bs. But I'm busy, and it's just more convenient for me to do it on demand. But now I have to take time out of my practice, out of my schedule, out of my family, and go and spend money and do all these things. So they have combined them into 1B. And that was actually the last cycle. That was 19 to 21, was whenever they did that. And so, especially with COVID, they extended it, okay, you can do the 1B, the 1As, on demands, 1As, things of that nature. So, but to answer your question, long story short, check the AOA, because they will change it. They have not printed the AOA CME guidelines for this cycle yet. They, because of COVID and them being out in meetings and everything, they have not published it yet. Hopefully we'll have it by House of Delegates in July. Knock on wood. So we shall see. We hope. But so back to is there any more questions? Okay. So with that, I have 15 minutes. Yeah. So with that, and I can't touch the floor, so I always sit on my feet because my feet go numb because I can't touch the ground. But with that, Category 1s, and one last thing, we have a good relationship with the licensure board. We are allies, yes. They don't want to catch y'all. They're not actively looking for you messing up. We do not. They do not. I know I'm speaking for them, but we work with each other hand in hand. We don't know what's going on if you do mess up. It's not our business. But if you need CME and you talk to them saying, okay, no, I don't have enough, come to us, or they'll refer you to us, or we're going to work with you and help you. That's one of the main things. And I'm sorry, I'm speaking out of turn with licensure board and not the OA. But that is what we are here to do. We are here to help you succeed, never fail. And if you ever need anything, you're more than welcome to contact me at the OA. My name's Audrey, again, spelled A-U-D-R-E-Y, just like Hepburn, but not as classy, and at okosteo.org. You can always email me and answer any questions I can, and if I don't know, I will find out. So with that, here's Christi Aquino. She is an Aquarius. She likes long walks. I'm just kidding. Like I said, this is very informal. I'm not an Aquarius. Scorpio. Anyways, I am Christi Aquino. I am the Director of Licensing at the Osteopathic Board. And you probably have already seen me because I think I've come to most of everyone's residencies and spoke about getting licensed before in the past. Oh, you're in Missouri. Oh, are you coming here? Oh, you're from here. So what are you, PGY 1? Oh, that's awesome. You're about to start your PGY 1s here. Oh, that's awesome. And are you starting your PGY 1 too? Finishing, perfect. Well, that's perfect because I just got done doing a whole bunch of, Audrey's about to say something. I remember whenever y'all joined medical school, those, the stethoscopes. Yeah, I trying to help Joe pick them out. So just saying. Anyways, carry on.
Wow, that's awesome. She remembers you. So well, this is great then. She never heard me speak before. That's good. So this is all going to be new. We just received a new licensing system called Thintia. We had paper forever, and we just got it in December of 2020, and it's awesome. I don't have to do any more paper apps. I used to have packs of them on my desk, probably 170 to 200 on my desk, and it was crazy. I had to go through each thing. So now we have an online system, and we're developing it. Actually, I would say every few months we're developing more and more for you to do. Kelsey Deviney is our business manager, and she runs our website, and this is going to be cool. You would love this. She's in process right now. She just emailed me the links for me to check this, and she just made it to where physicians can now upload documents after they log out, after they submit their application for licensure. They can log because usually it closes you out. You can't go back in and upload your documents. Well, now it's going to allow in the next few weeks you to go back in and upload documents, so we don't have to do it all for you. So that's great. So I'm going to speak on license renewal. So our license, our annual, our year is July 1st to June 30th every year. So we open up every single year for renewal. Some state boards do every 2 years, some do birthdays. We do it every year. So May 1st to June 30th every year, you need to renew your Oklahoma license. It's $225 in state, and we are just getting it passed where we're making it $225 for in-state. And I think our executive director wanted across the board $225 across the board for renewal. So when you go into our system, before you begin, this isn't to get licensed. That's a whole nother thing. This is for your renewal. So when you go in to renew your license, before you begin, you'll have to have your actual CMEs with you, your proper prescribing course information, your OBN registration number. A lot of doctors actually forget to have their registration number with them. If you're writing, controlled or controlled substances. So make sure you have your OBN number, registration number, and your expiration date of your Oklahoma Bureau of Narcotics, Dangerous Drugs registration number, and the expiration date, and also the payment method, like your credit card, with you, ready to go for your renewal. And you'll go to the licensee login. You'll log in with your email and password. And by the way, we're really letting doctors know not to put their actual, when you log in for the first time, or if you already have a school ID, email, like if you're working at Southwest Medical or OSU, and you have you're a resident, you have the resident hospital email, I would suggest you do not use that, because your ID, your login, is always going to be your login. So I'd use a Gmail, Yahoo, Hotmail. The cool thing about this also, that I made this, we were very adamant in our office about this, your password will never expire. And I hated that. Every 30 days, every 90 days, I'm like, oh, people would call us. I'm like, oh, and we'd have multiple phone calls, and we would have to try to get it. It was horrible. So your password, do a password that you'll always remember, which most of us have the same password that we use all the time. So password will never expire in the system. So when entering a practice address, we have a lot of doctors lately, and they're mostly older doctors, that are putting in their home address for their practice address. And I'm just like, why would you do that? That practice address is public. So one thing that we don't do that most medical boards do we do not put your birth date. So your birth date will not be on our public site. Your practice address will be on there. Of course, your full name, your first name, your last name, your license number, where you practice and where you went to med school and where you graduated, what year you graduated will be on the public site. We don't put your own. We actually have patients that actually will call us. Well, I need to know how old he is. Okay. We do have patients that do that. I want to know how old she is. Is she 50 or is she 29? She just get out of, because that means a lot to some patients. They want to know if you've been 20 years, or you've been in practice for 2 years. That's a big deal to some people. And we're just like, okay. But we do not tell them. I am very picky with our staff too about not giving out information at all. Like I don't even, is he from McAllister? Is she from Tulsa? I'm sorry, ma'am, we can't give that information out. I'm very personal about that. So
they don't even give it out to us.
Yeah, Audrey just said we don't. We're pretty strict. Like we don't even. Audrey asked me for an email when I first started, or like 2 years after I started. And I was like, we can't give out emails, and we can't even one email. And it was a doctor that comes in all the time. We don't even. You're gonna have to ask that doctor. Like we just can't do it.
I need his email. The doctor for his email.
And so we're just real strict about that. We don't give out any personal information. So, and like Audrey said, the OOA is advocates for doctors. That is awesome. Actually, I love that. We are a licensing board and we also discipline. So we are in the same building and the doctors actually, we will never move. Right, Audrey? Yeah, we probably will never move. We try to get our own place, but the thing is doctors come visit both of us all the time. They'll come over to our place and they'll go visit them. They'll come to their place. They'll visit us. It's easier for our doctors. Actually, it is. So to say that, we always have our door shut because our investigator's on the phone talking to someone who's complaining, or we have an irate, we've had this before, I promise you, they probably heard loudness in our office.
It's usually Christi's laughs.
Oh yeah, it's my laughs. I'm always happy. But yes, so they come to our office and then, they'll talk to the investigator and they'll be upset about something. But most of the time, if there's a complaint, they will call. But we do have the ones that will drive from Tulsa to be face-to-face with an investigator. So lovely. And we always have our door shut because we don't want, it's private. So we don't want anybody knowing, that someone, did something, a boundary issue, or, did something they weren't supposed to do, or the doctor was drunk or drugs, or that happens. So, so back to this, but yeah, so we do those things. So do not put your practice address. Some doctors have been doing that. We've been calling them. We take our time out to call them because it is public. When you're doing your application online, it's the same as renewal. When you see a red asterisk, you will not be able to move forward. You will not be, the system will not even allow you to move forward without putting something in. Like it won't even, you'll say, move next, next window. It won't even, but what's cool is, of course, it'll show you where you need to correct your mistake. So, and when answering updated professional, we just updated our professional standards questions. When you actually fill out a new application, there's 23 questions. When you're doing the renewal, there's only 9 questions, thank goodness. And then we just updated them. And if you answer yes to any of the 9 questions on renewal, make sure you provide what is stated to provide. If in the last 2 years, I think we changed one of our questions instead of last 12 months. In the last 2 years, have you had a DUI, or in the last 2 years you've been arrested, or, any of that. If you have, be honest, because we do investigations also, so, you'll definitely find out. If you are wanting a dispensing permit, you can request that when you do your renewal online. They'll be available in your place of practice records. So when you're looking at your place of practice, when you're doing your renewal, you can click on it. It's $50. The dispensing permit is like a pharmacy in an office. So the medical practice. So Dr. Smith has his own practice. He has his own pharmacy in his practice, and he's actually dispensing medications, controlled drugs, scheduled drugs. In his practice, he has to have a dispensing permit to legally do that, and that's $50, and that's $50 extra on top of your $225. And you can request those in your dashboard at any time, actually. So we had a doctor the other day request 4 of them. So he paid the $200, and we have them online. You can actually now print your own. You can print your own license online. You can print your own dispensing permit. You can pretty much print anything on our dashboard, and you can request your own license verification, and I usually approve it by the next day. We mail it out the next day, whatever you need. Secretary of State letters, we have it all, everything's to your access.
So if I have this cool stationery with waves and shellfish and like nautical with sailboat in the background, and can I put my medical license on that?
Sure, you sure can. Yeah, you can print it yourself, and you can make it a note. You can make it a notepad.
Question in the back.
Yes, ma'am.
No question, no question.
Is that only what you need for dispensing narcotics with your office, or do you need that for other medications as well?
You need it. Oh. The question was, do you need a dispensing permit if you're only dispensing narcotics? Or do you need it for dispensing other medications as well? You have to have it no matter what, if you're dispensing anything. Anything at all. If you are giving a shot, you have to, a testosterone shot, you have to have that. Well, testosterone is controlled, of course, but if you have to have a dispensing permit. That was a good question, because we've had this before, where if you have, a lot of doctors get samples. They get a lot of samples. You do not have to have a dispensing permit for samples, because that's a sample. You're giving a sample for them to try. That you do not have to have a dispensing permit for that.
So like 800 milligram ibuprofen, which is very common amongst physicians to prescribe for pain.
Yes,
So
you have to have a dispensing permit if you dispense any medication at all. Mm-hmm. Mm-hmm. Yes, if you give a steroid shot, any kind of shot, yes, you have to have a dispensing permit, and it's $50, and that lasts from July 1st to June 30th.
Is the window to purchase that only at renewal?
The question was, can you give the dispensing permits any time of the year, or can you only purchase them at the time of renewal? You can purchase them any time of the year. And it's funny, because a doctor just purchased one last month, and I'm like, they're about to renew their license. Like, why would you do that? So I called her and I said, Dr. So-and-so, did you mean to just, did you mean to request a dispensing permit? Because once I approve it, that $50 is in. And she said, yes, ma'am, I sure did. I just opened my new practice. And I went, oh, and it just opened the next day. And so she had to have that in order for her pharmacy to even be legal. So. Well, each state is different. And I found that out too. Yeah, because like Louisiana, Missouri, Texas, everybody has different Bureau of Narcotics. They all have different rules. Oklahoma has this different, and they've strapped down a lot. 3 years ago, they came out with some tough, like, none of this, none of this, none of this, none of this, and no, all the way down. And doctors were like, oh my gosh, they're making it harder and harder and harder. And we're like,
actually the AG at the time that did it, and unfortunately his son died of it, or I'm sorry, no, not Mike Hunter, but Bob Howard, who owns the car dealership, his son passed away of a drug overdose. of narcotics prescribed by a physician. So through everything, my counter, who was the AG, unfortunately, he made an example out of a DO. Of one of our family members. And she was sentenced. She was found guilty. And so they made an example out of her. Whenever a lot of them that have done worse get a slap on the wrist, but not her. She was facing jail time. And sorry. Oh, and real quick, there was a question: as a graduating resident this year, how do you track my CMEs in the 2022-2024? Oh, you got that one?
That was about to come up. I'm about to answer that one. The tracking. Okay, so when you're putting your CMEs in, so we do not, okay, so we email everyone, all residents and doctors, period, should have received an email. And once you're in our system, the email that you put in, you'll get all your information from us. We emailed an email sent out that actually said this answer, that we don't, it's your responsibility to keep track. I know way back before I started, Barbara, who was before me, she had file cabinets, a lot of them, full of CMEs from like 1992, like just kept them. And I'm like, why are we doing this? Why are we holding doctors' CMEs for them? I don't understand. Please help me. Like, why are we doing that? Like, so like Audrey had said though, if you need a copy from the OOA though, the OOA has copies, or they'll have, they'll email you something stating that you got it from them. But the biggest misunderstanding is that the OOA can track every CME that a DO has, because they'll call the OA and they'll call us. Well, the OA is saying they don't have it, so you must have it. No, doctor, you have to keep track of your own CMEs. Well, I don't even know where oh, well then how would we know? You know what I mean? So it's like, they keep track of what they do. The AOA keeps track of whatever is sent to them. You know what I mean? Yeah, so pretty much you have to keep track of your own. And you can always, everything is uploaded. So the minute you do your CMEs, I would suggest you to upload it right away. Because what happens is, if you get audited, I'm just gonna go click, oh, she uploaded it, click, download, oh, there it is, okay, hours, done, approved. And we do about 50, there's about 50 DOs that get audited randomly, and it is randomly, we do not pick them. It's randomly selected every year. So they do, so if you already have it uploaded, now the system is awesome. We used to get fax. So yeah, it was nuts. So you're good. Okay.
I apologize. I think everybody, I have to. Rick and John should be here.
Oh, gee, okay.
Oh, they got some stories for you.
Oh, yeah, they do.
Like how people have messed up.
They do. I work with both of them. They're both investigators.
If y'all have any questions, please shoot me an
And
email.
it'll just pop up. Okay, got it.
Yeah, that's what I
Gotcha.
captured on.
Thank you, ma'am.
You're welcome. Thank you.
But yeah, that's pretty much for the dispensing and the CMEs. Once your renewal is approved, your updated license certificate and wallet card will be available in PDF formats. And they're listed under certificate and pocket download on the left hand. You'll have a dashboard. It'll be on the left-hand side of your dashboard. So you can just print that out. We used to mail out this bright yellow, lovely renewal, and it had the little pocket card on there, and doctors were so upset because they're like, I want my little wallet card. You're not going to send it to me? We had multiple calls about that the first time we had our system. I said, wow, goodness, what are we going to do? So we're trying to figure out a way to where we can get that somehow, but we haven't, because it's a pop out, you know, it's one of those pop, like, how are we going to do that? Like, you print it, you know, we're not going to mail those out. We used to do old school, like they'd line them up on the tables. These big bins would come in from central printing. Yeah. So someone renews and we'd pull a list of like, you know, 300 and then like flip through them. Oh, pull that one out, pull this last name. And we'd have to mail them out and pay for mailing. And now I'm like, okay, no, we're not doing that anymore. So when you renew, we'll go in and it'll be approved. If you answer yes to a question, I'll definitely be reviewing it. And I'm telling you right now, most of them, yeah, probably at least half of them are going to go right through. Right through. We don't get a lot of yeses. If I have a question about a yes or about something you uploaded, I'm going to call you first. I promise you, I'll call you first before I'll take it to my executive director. And he already knows that because we already talked about it. And if I need more information, I'll say, Dr. Smith, I still need your court order, or this doesn't say enough. Could you please give me some more information? Because I really don't want you to be in trouble either, you know? So all that to be said, then if I have a question, you have a DUI, you know, 6 months ago, you're gonna probably come for the board, the next board meeting. We've had a few of those, just this last year. So that just definitely answered yes to all those. Receipt, you could get any receipt if you paid for something. We used to have a lot of doctors call about receipts, and we had them, had to do them manually. We were like one of those behind the time boards, not anymore. So now you can just pull up your own receipt, click on receipt, print it yourself, download it. I love it because I can just download it and send it to my email. So even when you do your license, you can, it's on the left-hand side of your dashboard, and it's invoices and receipts. And I love it because I'm like, we need a website that's like 3rd grade level, because I'm that way. I need it to be like, this is it, a place of practice. Oh, I know what that is. So it needs to be very simple. I don't think that should be hard to do, So the renewal actually takes we went through a renewal, it took about, 13 minutes, but that was doing it pretty fast. If you take your time, it might be 15 minutes, maybe. I don't know. How long did it take you to do your renewal last year? 10 minutes? Yeah. Yeah. That's right. Oh, and we have a drop-down box for those. Yeah. So when you do your CMEs, you have a drop-down box, and it goes, and you can just pick which one you did, or the proper prescribing. Proper prescribing, we have to have. The proper prescribing is very critical. We have approved proper prescribing 1-hour proper prescribing courses that you have to choose from, and they're on our website. You can't just go to a proper prescribing 1-hour class. Now those are on our front page of our website. There's a list that you could just choose all over the state of Oklahoma, different places. I bet OA is they are the ones who cover pretty much all the proper prescribing. Yes, ma'am.
So those are not interchangeable among states. Like Oklahoma's are specific to Oklahoma licensure, and then Missouri to Missouri, and then Louisiana.
Yeah, so are they interchangeable from the states, like Missouri's, Oklahoma's, so on and so forth? Yes, they are not interchangeable. If you do a proper prescribing, it has to be an Oklahoma proper prescribing class. You cannot do one in Missouri for Oklahoma, because each state has different prescribing dispensing laws. Yeah. So that was a great question. That definitely needed to be said, because I know some people want to do that. Oh, I'm going to be in Texas, for the summer. I'm going to do locum tenens. I'm going to be there anyways. I'll be with my friend. I'm just going to take this class. That's happened before. So definitely choose from one of those. And one of our DOs has to be present. That's one of the rules. One of our actual DOs in Oklahoma has to be, I think it's, I get that right. One of our I'm sorry, I think it's board member. I'm sorry, I think it's our board member. It used to be our board member. I think it might have changed. One of our DO board member has to be at that. That was 3 years ago. I think they changed it to a DO has to be present. I don't know if it's the OOA, and I'm not sure. I'll look that up though. But a DO has to be present at that proper prescribing. I know that for sure. Has to be present for that class to even happen. And it has to be approved by our executive director. OOA, automatically approved, no matter 100% always approved. But there's been other, OSU is usually automatically approved because we know these DOs too, like Severa, Dr. Severa, he's at some of them, and Dr. Lane, there's a few doctors. So it definitely isn't our board member, but it is DOs that we know. And we approve those proper prescribing classes. And then Audrey had talked about the category 1. So I've been doing this for 10 years. So I'm gonna tell you right now, we have a few, we don't have a lot. We have, I would say, I don't even know how to even I don't know percentage wise, but we have some that do category 1B. And that could be a preceptor. They're over another, resident or, a doctor who's in trouble. A preceptor would walk them through, that is hours and hours. So they can count those hours, but they have, that all has to be shown on paper. It has to be shown to us. We had a lady, a doctor, she did, what was it? Oh gosh, I think it was 50 something hours of journaling. It was really cool. And so, and then teaching, there was a teaching, she did, another guy did a teaching, he taught at OSU some medical classes or at medical school. I mean, those count though. So long as you can prove it, so we have to see that it's approved, we have to prove that. So some have done that, but I'm gonna tell you, most DOs, they definitely do the 1A, the classes, the conferences, the listening and getting the teachings. Out of state DOs are exempt from the 1 hour proper prescribing because they're, the out of state DOs are exempt from proper prescribing because they're not in state prescribing. Residents and fellows are exempt from CME and proper prescribing credits. So as a resident, you don't have to do the 16 CMEs. And it used to be a confusion. It used to be okay, we do 16 CMEs and we do 1 hour proper prescribing. No, you could do 15 CMEs and 1 hour proper prescribing equals 16. Yeah, that was a confusion a while back. And let's see, yeah, so residents, if you're a resident or a fellowship, you do not have to do either one because you're already getting all your training. You're going through training. And it's your responsibility to maintain that file that will verify your compliance, CME rules, and you are now able to upload the CME certifications if you choose also. You'll not be allowed to complete your renewal before the June 30th deadline if you have not received the CME. So we've actually had quite a few doctors that either forgot or thought they took their CMEs, and it's June 15th. And they're freaking out, and they're like, "What am I going to do? Oh, Ms. Aquino, oh my gosh, I can't renew. I have to pay the $150, and the next class is August 5th. What am I going to do?" Well, you can go ahead and renew now, but you're going to have to pay the $150 no matter what, because you're going to have to put in the August 5th date, and it's automatically going to put you into late status, and you're going to have to pay the $150. So no matter what, the date is going to be late anyway. So. And I know the OA, they don't do anything after, I think they did proper prescribing in June. They usually do it in June too. Proper prescribing is not hard to get. It's the CMEs because it's 16, but we have a number that you call OSU. OSU has online CMEs that you can get with a login and stuff. That we have a number that you can call them and they can get you set up. And then I don't know how much it is now. It used to be fairly cheap from what I heard from DOs. At one point, it was $15 a credit. And I was like, oh, wow. But that was a last minute ditch effort kind of thing. That was like the last 2 weeks of June. So you don't freak out about that. If you plan to receive your CME July 1st, August, you definitely you must wait until July 1st or after. They're saying this on here to renew your license with addition of $150 late fee, but you can put in that late date and get that done. Do you guys have any questions so far? Yeah. Let's see. For the initial application, you're just filling out the application to get licensed. Once I approve your license with all your documents in, then you can go in, you're licensed already, you click on places of practice, and then the screen will show up, and then you'll click on the left side, I think it's the left side, dispensing permit. And then you just pay at the end, or right where it says it. Yep. Do you have any questions? Okay. Anybody else? I think we're really good on time. I don't think of anything else I could talk about or see anything I left out. See if there's any more. Does anybody have questions online? Let me see. I'm trying to think of here. If you're not going to prescribe, you don't need an OBN or DEA. Also, if you're getting licensed, you'll have to have your license number to get your OBN registration. And you have to have your OBN to get your DEA. So it goes license number, OBN registration. It takes about 3 to 4 days, maybe a week. Then after you have your OBN registration number, then you can apply with DEA. And that takes about a week and a half to 2 weeks to get your DEA number. And a lot of doctors always forget they always used to in the past, they would forget to have their OBN number with them when they renew their license. So definitely have that with you, and just for this new system. They forgot a lot last year. But yeah, that's pretty much it. You're welcome.
The plan for some things, but those were really legit questions I had. That's always been a question of mine from the Louisiana standpoint.
Oh, really?
So we've got the CES it's supposed to be like our OBN and stuff. And so that one there was one year that I forgot. I said that I was doing schedules 2 and 2N and everything, because I thought that if I clicked those, then it ended up covering 3, 4, and 5. Turned out it didn't. And so there were a couple of years there where it showed I was just prescribing 2N, which I don't really prescribe those. I prescribe more the 4 and 5 and everything in the few times I do prescribe. And I was like, oh crap, this is a big deal. and they were nice enough to notify me without any penalties or anything. But it was in between the DEA years.
Oh, wow.
So, yeah, but trying to figure out.
I like those questions, actually. That was really good.
That was like the questions from the season question form.
Those are good questions, though, because those have always been questions that people called about. Always. Like, it's confusing. It gets very.
Especially for traveling state lines and stuff too.
Yep.
If we end up doing some CME in one place versus another, how much does that count? And if proper prescribing is the one that does work.
Yeah, no, really, yeah. Yeah, because neighboring states are like, locum tenens, people want to do emergency med lately is wanting to do a lot of locum tenens. Like, they're just I'm like, oh. Yeah.
And so it's like,
yeah.
I'm going to go to Florida.
Yeah, it's really weird. Yeah, it's growing too. A lot more people are going moonlighting and locum tenens lately. I mean, it's a lot more out there. I think it's kind of cool though. I mean, they're expanding themselves since COVID. That's what it is. Oh. Okay, how did she do that? She does it on here, but I don't know how she did it on there. Or how did she get her mouse on there? And I can't use that on here, but yeah, like I can use it on here, but I can't use it on here. You see how she does this? Look at this.
Good afternoon. My name is Rick Zimmer. I'm the Chief Investigator for the Oklahoma Osteopathic Board. And I have with me John Mobley, Special Investigator for the board also. What we're going to talk about today is prescribing issues, and we're also going to provide you some information as to some cases we've worked in the past and how the doctors have gotten themselves in trouble. Hopefully some of these examples will help you all in not following in their footsteps and ending up in front of the board. So, board was established in 1921. There's no conflicts. We are both employed by the state of Oklahoma. We're going to go over some requirements of your prescribing based on what DEA requires, OBN requires, and what we require. We're also going to provide you some red flags to look out for as you're prescribing. Our staff, there's 7 of us, and then we have 2 attorneys that are contractors. Mr. Gamino, who has been with us for 20 some odd years for our board attorney. Mr. Quillian is our special prosecutor for the board. Mr. Lee, because our executive director, he's been here a little over 2 years. He's a lawyer. Myself, I've been in law enforcement a little over 44 years. Mr. Mobley, the other investigator, has been in law enforcement 3 months longer than I have, 44 and a half years. So, Ms. Aquino, the licensing director, you may have already met her. Ms. Devaney is our office manager. Ms. Contreras assists us with our investigations. And Ms. Womack assists with licensing and our receptionist. Our current board, the gentleman on the far left, Dr. Derby, he was a board member. Unfortunately, last year he passed away. We have Dr. Ogle in the orange tie, emergency medicine doctor. Dr. Taylor is a family practice. Ms. Templeton in the middle, she's our current board president. She's an attorney in the malpractice insurance area. Dr. Langerman's an emergency room doctor in Oklahoma City area. Ms. Taylor is a workers' comp attorney out of Tulsa. And Dr. Young works for OSU, and I think he's here in the Oklahoma City area. Dr. Carter, who's not pictured here, just got placed back on the board to replace Dr. Derby's slot. We also have a Dr. Jay Cunningham. He's an anesthesiologist in Oklahoma City. One of our edicts for the board is to protect the public, and part of that protection of the public is done by using state and federal laws, state administrative rules and regulations. We do enforcement of those. In our licensing, we screen our applicants thoroughly, ask for a lot of documentations, as you all know, and we also educate doctors. OBN, you fall under some prescribing issues with OBN. You have to have a registration with them, a drug registration, and that gives you the ability to prescribe 2 through 5 scheduled dangerous drugs. And it's the responsibility of the registered participant to guard against drug diversion. You must also make sure you're prescribing those medications for legitimate medical purposes. And you may not prescribe a patient to continue his dependence on a drug. In the federal system, it's under DEA, it's under Title 21 of the U.S. Federal Code. here in this area that you are required to guard against diversion of CDS. Also, you must know that you are not allowed to employ anybody in your office that has a felony conviction for a drug related to controlled dangerous substances. 2-3 years ago, we enacted the state enacted Senate Bill 1446 and 848. There's some exclusions to that. If you're prescribing for a cancer patient, a hospice patient, or palliative care, long-term facilities, you don't have to follow the 1446. See, the other thing it did require, DOs used to have to do a proper prescribing every other year. This bill requires that all physicians in the state, DOs and MDs, go to a proper prescribing course every year. And you must attend a course that we post on our website every year. If you don't use that particular course it's posted, it will not count towards your CME for the proper prescribing. The PMP, you're required 2015 statute came out that said you will check the first time prescribing and once every 180 days for opioids, synthetic opioids, benzos, carespronal. You'll check those every time. As a doctor, you're going to have, and you've got a registration through OBN, you'll have a PMP registration, which will allow you to get in and check those PMPs. We suggest you check your PMP on a regular basis, a yearly basis, to make sure that somebody else isn't prescribing on your number. We also recommend that, and you are allowed to do this with through OBNDD, is a medical assistant or nurse can register as a delegate under your name, and then when they run a PMP for your patient, it does show up as you've checked that patient for whatever narcotic is required to be checking for. Also, if you have patients that have over 100 NMEs, you need to clearly document as to why the purpose is, justification as to why you're prescribing combinations of drugs over 100 NMEs. This is a pain management situation, so in order to properly prescribe these people, you must do a physical and history, you must establish a doctor-patient relationship, and if this the first prescription 7 days, the second prescription 7 days. If you go to the third prescription, then you're required to have a pain management agreement. Discuss the risk management for benzos and opioids together. If the patient is pregnant, then must sign a pain management agreement. And also, if that patient is under 18 years of age, you must have that pain management agreement with the parents or guardian. You also will need to be posting a policy in your office as to how you're going to treat and prescribe opioids. Prior to that initial script, you need to have a thorough physical and history on the patient, conduct that good physical exam, develop a treatment plan, access the PMP, and check that narcotic that you're going to prescribe. And, here again, if the patient is under 18, a pain management agreement with the parents, and if they're pregnant, you need a pain management agreement. Informed consent, you will need to discuss and document in your charts your discussion with the patient that deals with the risk of the narcotic you're prescribing, so that they'll understand that there are some risks that go along with this particular drug. Make sure you document. The key to a lot of this statute is documentation. You need to document in your patient's charts of what you've done. I'll go back to something you've all probably heard in med school was if you didn't document it, it didn't happen. It's the same in law enforcement. If we don't document it, it didn't happen. The Senate Bill 1446, 848, it's a little bit breakdown of how to prescribe it. We also have on our website, one of the tiles on our website is a copy of what we consider what's called best practices. This Templeton put it together when these bills came out, and it's an explanation, basically the same explanation you have here. Your first prescription is for 7 days. Your second prescription after you've assessed for that, after that first 7 days, is for 7 days again. However, there's an exception that you may go ahead and issue that second 7-day prescription. We have to put on that prescription, do not fill before the 8th day. And that way the patient, especially if the patient's had hip surgery or knee surgery, doesn't have to actually come back into the office. They can go ahead and get that second 7-day script. If it goes to the third prescription, which can be a 30-day prescription, there again, then you need to do a pain management contract and discuss those risk and managements of taking that particular drug. You can reassess the patient. It's recommended that you do the face-to-face reassessment. However, it's not required. Just make sure you document that a reassessment was done on the date and that you went ahead and script them for the next prescription. In Oklahoma, as a doctor here, we have the Oklahoma Osteopathic Medical Act, which you work under. It's in Title 59 and Section 623 forward. And then we also work under the Oklahoma Administrative Code, Rule Title 510. It deals directly with osteopathic examiners. The last time that the board revised that was in 2016, and within the last 6 months, we have gone through a revision, and it's been finalized. It has been sent to the governor's office for finalization, and once it gets back, we will post it on our website, and you'll receive a notice that we've had some rule changes. One of the rule changes that will possibly help you at some point is we went from being able to supervise 4 mid-level practitioners to being able to supervise 6 mid-level practitioners. So that is one of the major rule changes in there. So both of these, the Act and the statute, are on our posted on our website if you want to look further. What the Title 59 allows for the board to do to employ investigators, which John and I have been here for a while, and it gives us the ability to come in and inspect records. It is to ensure that you're compliant with what the state and federal law and rules are in your practice. And as a result of us licensing you, it is deemed that you have given your consent for us to do that. You can refuse, but refusal is considered a violation of our statute, and more than likely it will get you a trip to the board to explain to them how come you don't want us to look, that particular doctor does not want us looking at their documents. I will tell you that if an investigation is started and we need medical records, we are probably going to issue a subpoena for those records just to safeguard ourselves and to safeguard you all. So the process, we have the new online system we have. It has online reporting now. When those complaints come in, they're reviewed. They are put in a stack, and we have a case review committee that meets once a month to review those documents, those complaints, to see if there's an issue there. And by the way, if a complaint comes in on a doctor and we do not go forward with it, the doctor is never notified that we had received a complaint against the doctor. So only those complaints that move forward and result in a formal complaint being presented before the board will, at that point, the doctor will find that out. The medical review committee consists of the director, 2 medical assistants, advisors, 2 DOs, 2 investigators, our prosecuting attorney. We review these documents, complaints that come in. We do add extra documents that would assist them in making final decisions on which way we should go with these. The case at that point is either open or closed. If we close it and don't go forward, then we'll notify the complainant of, for whatever reason, that we don't look at it. If it's given to an investigator, investigation's done. Once that's done, it's brought back and reviewed to determine if we have enough for a violation. If we do, then the prosecuting attorney puts together a complaint, and we present it before the board. Complaints come from everywhere: physicians, doctors, family members, pharmacists, DEA, OBM, law enforcement. Whoever wants to take time to fill out a complaint will review it. So everything that comes through our office is reviewed. Like last year, we looked at approximately 250 complaints. Did we investigate that many? No. But we reviewed everything that came through. Medical review committee consists of, like I said, the director, the prosecuting attorney, 2 investigators. Our investigative assistant is in there to document what we're talking about, and our medical advisors. We're trying to determine if, with the information we have put together, if there's a violation of our medical act or of the rules that we work on. Outcomes are there's either no jurisdiction, no clear and convincing, or we felt that that was the doctor's independent medical judgment. Either a partial or full investigation, just depending on what violations we think might be there. Things we look at for consideration in these cases is how much drugs are you prescribing. If you're prescribing the cocktails, you're failing to check the PMPs, and if you have deaths associated with your practice. If OBN is a repository for the overdose deaths that the medical examiner looks at. So if we're looking at a doctor and he's got multiple deaths, then we're going to pull all the police reports and all the reports necessary to determine what it was, and we'll put that with PMPs and a few other things that let the doctors review. Also, we'll look for MMEs. There's not a set standard. I think the CDC recommends under 100, and every place is a little bit different. So we always, when John and I review these PMPs, that's part of our review to see how many patients you have over 100 MMEs. So red flags, patients coming from all over. If they're driving past 2 or 3 major cities to get to you, to see you as a pain management doctor, and why? That's what we'll ask. Multiple prescriptions to the patient, if you've got poor medical records on the patient, early refills, and also if you're seeing 100 patients a month. I looked at a case where the doctor was seeing, 100 patients a day. I had a doctor seeing 100 plus patients a day, and every one of them was getting 5 to 6 scripts, and so it was very common for him. His prescription average per day was 186 prescriptions per day. So he also had 9 deaths associated with his practice. So he came to the board and spent 5 years on probation with us. So that's just the type of cases we're looking for. High number, high dosages, multiple prescribers. If you're seeing a patient and you haven't checked the PMP on that patient and don't realize that patient has seen 6 or 7 other doctors, that is an area that we think that patient actually is doctor shopping. So that patient you should probably consider having a visit with, or get that pain management contract, as I think most pain management contracts limited your patient to you only as the doctor. So multiple overdose deaths, cash. It's a cash business. John and I were at one of our clinics one day waiting to pick up some records, and the doctor probably saw 15 patients, and every one of them was a cash payment. He was in there less than 5 minutes, and each one of them came out with 2 strips. So that doctor surrendered his license during our investigation. The violations, obtained a license through fraud. If you all haven't renewed the first time, or if you are filling out the application, there's a series of questions. Your renewals also ask a set of PSQ questions about, did you have lawsuits? Did you get terminated or disciplined from a program? Did you have a DUI? And please answer those truthfully. Doesn't mean you're going to get in trouble. What it does mean, if you don't answer them truthfully, technically, you've obtained a license illegally, and which in this state's technically a felony. We don't file criminally, we do administrative. We'll go through a few of these. Performing inappropriate or unnecessary treatment, delegating supervision. Supervision is a big area because at some point you may decide to supervise a mid-level, a PA or a nurse practitioner. If you ask them to do something that's outside of their scope, then technically you violated that particular statute, and it happens. Or if that mid-level does something without your permission, they're in trouble with their board, plus you're going to be in trouble because it happened while you were supervising. Everything with supervision. If you get disciplined by your hospital or your program, that's a violation. I don't know, it may be something that comes to the board. It may be something that's handled by the case review committee. I just don't know. The big one is, here's a big one, is signing blank prescriptions. We had a physician, she was leaving her current job and she felt like it wasn't covered, so I think she wrote 25 blank scripts and signed them and told her LPN and PA just to give them to the patients that needed their prescription. So that was not appropriate. Also, prescribing to a patient without a current or establishing doctor-patient relationship. The telemedicine portion of this kind of goes into effect here because in order to write, under our rules to work telemedicine, you cannot write Schedule 2s through telemedicine. You have to establish, in order to write that Schedule 2, you first have to establish a doctor-patient relationship, face-to-face relationship, to establish that, being able to go on to telemedicine. Sexual relationship with a patient within your practice. That's a big area of concern. It happens. So the board takes that real serious. One thing we get quite a bit is doctors failing to provide the medical records when the patient requests them. You can, to provide medical records, you can, as per statute, charge them the fee for that. And I think most doctors' offices have the patient sign a release for that. So we've never brought a doctor before the board because of that. We try to work pretty much with the doctor and or his office manager to get those medical records released that are requested. If you're on a board order, you violate that board order, you're going to have some other areas. Gross negligence, malpractice, gross incompetence, that's determined by the case review committee at the time when we start seeing things. We also look at National Practitioner Data Bank reports that come in. We're just trying to monitor to make sure the doctor doesn't have 6 or 8 in a very short time period, because if we have that, then our medical advisors feel that we may have a problem with that doctor and what he's doing. So, and if you get adjudicated for a criminal act, and the most criminal acts we see are the DUIs. So I think John's going to visit with you all about the DUI situation and how we handle them.
Okay, DUIs are a plague on the medical community. Basically, you've heard a lot of stories about DUIs having crashes and people finding out that the board knew that they had prior DUIs and they did nothing about it. So that's not going to happen in the future. A little bit about my background. I've arrested probably over hundreds of DUIs, so I know the way to look for them. I know how they get past us. I know how you can avoid it, and I know what gets you caught up in it. If you do get caught up in it, you can bet it's going to be hard to beat the tests that they're going to give you. They give you, there's 3 tests. One's a one-legged stand, one's a heel to toe, and one is a nystagmus test. And you might be able to beat 1 or 2 if you've been drinking, but you won't beat 3. And if you feel like you can, try it without drinking. Do a one-legged stand and hold your leg up for 12 seconds and see if you can do it without drinking. But remember, what gets you in that position is the officer's going to get an odor of alcohol from your breath when he's talking to you and getting your license. Once he's got to that point, he's got probable cause to take you out of the car and give you the field sobriety test. We do want to say though that it's not the end of your world if you get arrested for a DUI. It is uncommon, but we do see them. We do try to work the doctors through them, and it all depends on their attitude, and it's all depends on how they handle it. If they come to us when they get arrested for DUI, we will refer them to OHPP, and if everything goes smoothly, they may never hear from us again. If we find out about it, either we're told about it, we see it on the news, or we pull up Oklahoma State Courts Network, which we do quite often, and see that there's DUIs there, or we may even pull it up when somebody puts it on a renewal. At that point, you've probably foregone your chance to go to OHPP and avoid a trip to the review committee. And again, it would be the review committee's choice. If you get a DUI and you don't report it to us and you get caught, just be ready to go to the review committee and explain after we've told you this that you didn't do it. We did have an actual case not too long ago. A doctor was driving home from dinner, and he pulled out from a stop sign and clipped a car with very minor damage. And of course, the doctor had been drinking wine at dinner, and he went through the sobriety test, failed, and blew, I think it was 0.10 on the breathalyzer, which is, right at the limit. Anyway, he came to us voluntarily without us being told, and we worked him through that process. He had a very good attitude. He knew he'd messed up. But I guess the point is, what I'm trying to tell you is if you're going to take that glass of wine and go to dinner, make sure it's just one glass. And if you are intoxicated, be aware that they're going to take you downtown Lynchboro into a breathalyzer. Hopefully, we won't be involved too much with you guys on the self-reporting of DUIs. But what I want to do while I got you is go over a few of the things, and this is what they asked me to do, is go over some of the things that brings your name to the attention of the board. And I'm just going to read you a few of our last case review committee complaints, just to let you know what we're seeing every month. Here's one that Arkansas suspended a doctor, and we're going to have to do a reciprocal order. We see a lot of those. So if you do get suspended in another jurisdiction, let us know so we can get the ball rolling on that. Lots of failures to report on renewals. Here's another issue that we've been seeing quite a bit of: Botox given by an unlicensed uncertified person. We see a lot of those. Boundary issues. We have some where medical records, either the doctor has trouble getting the medical records or won't deal with the patient. In that case, Rick and I tried to do it over the phone and just explain to the doctor that, let's get it over with. Let's send them the medical records and not have to come and visit with us. We have a case right now where a patient wants his record changed because he had an adverse condition on his surgery. And that just took a phone call from me to the doctor, and he's going to take care of all that. We have complaints on doctors supervising outside of his training and specialty. We have lots of malpractice suits. Now, those are individually, those are taken each individually. If it's a large amount, you may see us, and if it's a number of small amounts, you may see us. And again, if it's a few, you may not see us at all. So it's an individual deal based on the review committee's decision. I was going to tell you about recently, we had a complaint from a patient, and this was back when we had all that foul weather and all the doctor's offices were closed. One doctor failed to give any forwarding information. He locked his office and left and went home. And of course, we get a call from one of his pain patients saying that, hey, I'm out of medication and I don't know how to get a hold of this doctor. And we couldn't get a hold of him either, so Rick had to go out in that blinding snowstorm, knock on his door, and let him know that he has responsibility to take care of this patient. And I venture to say that won't happen again, and I hope doctors realize that that is their responsibility. But anyway, that's just a few. There's a bunch more. I won't spend any more time, but I was asked to let you know some of the things that we deal with, and that's that.
As far as the DUI goes, we had a doctor who had her grandkids with her in her car, and she ran a red light and changing lanes in the middle of the intersection, and it drew the attention of the police officer. Well, when he stopped her, she was intoxicated, and he was in the process of placing her under arrest and had to call somebody to come get the grandkids, and she didn't take real kindly to it, and she basically told the police officer for him not to ever come to her ER because she would place some instruments of body parts that he wouldn't like. So he arrested her, took her to jail, and she proceeded at bookend to tell the bookend officer the very same thing. So we get a call from the hospital's attorney saying they have a problem and here's what it is. So we had her under board order for quite a while. In those type of situations, that doctor, the board ordered her to get an evaluation. As a result of the evaluation, it was determined she had some alcohol disorder. So she went to a 90-day inpatient treatment. And those were expensive. I think that one was in the neighborhood of $50,000. And when they get out of that, they sign up with OHPP and monitor. In her case, it's a program called SoberLink. You basically have to blow into a breathalyzer 3 times a day, and you have a time period. It got to the point where, for some reason, she was unable to meet that hour window every day, and she just couldn't get it. And unfortunately, she got to the point where it cost her $1,000 every time she was 1 minute late on her SoberLink, and it got expensive for her. Had another doctor decide in the middle of the afternoon that he wanted some fish tacos, so he left his house after he'd been drinking and got stopped for DUI. So as a result of his, we found out he had 2 previous ones, and so the board, and then right after that, his employer had not taken action. They gave him a certain amount of time, and he didn't follow up, and they terminated him also. So after a year being with us and with OHPP, he called me up one day and said he just couldn't find a job. He's a surgeon. and that he was no longer going to be a doctor, that he was going to give up. Oh, and by the way, when he got arrested, he went to jail that night, and because of him being in jail, he missed 2 scheduled surgeries the next day. So, so as a result of him deciding, he decided he wasn't going to be a doctor anymore. He would rather, he's going to go build boat docks with his brother. So DUI is changing. It changes the whole scope. Is it the end of the world? No. If you tell us about it, if you go to OHPP and handle it through OHPP, we will more than likely not know about it. But if you fail to document those, and I'll just tell you straight up that part of when we get a new case, we run your name, we run the doctor's name through OSCN to see what's going on. And we discover quite a bit of information out there. Not only that, possibly some assault and batteries that we're never told about. But I think there's been a case recently where we ran the doctor and he had 2 previous DUIs we didn't know about. So that kind of gets the board's attention. If you get revoked, suspended, or reprimanded by any other state or federal agency, OB and DEA both have the ability to come to you and take your drug registration away. They can do an investigation. I know that if DEA does a show cause hearing because there's a violation with your prescribing practices, and they want to do what's called a show cause hearing, it's basically a hearing. Most of the time they hold those hearings in Washington, D.C. So not only are you in trouble with them, but now you have the expense of traveling to Washington, D.C. To appear before their hearing. So it gets expensive. I recently told one of our doctors who's young and got in trouble right before he got licensed, and he's had to jump through some hoops. But I told him, I said, it's real expensive to get in trouble with the boards. I mean, it is your license, but if there are consequences that go along with it if you violate these statutes or the rules. If you become medically or psychiatrically don't have the ability to discharge your duties as a physician, we need to know about it. If you guilty or have habitual drunkenness or addiction, the board is here to help you. We want to bring you in. We want you to come to the board. The board's going to give you that opportunity and ask you to go to an expeditional CME. So they're going to ask you to go get an evaluation so they can determine if you need to go to some inpatient treatment to address, a substance abuse issue. We use several facilities throughout the country. They're all very good. They've had very good success. Plus, you'll also be asked to go with OHPP. OHPP has about a 94% clearance rate. Clearance rate for it, but 94% of the people stay sober and keep going in their profession. So that's the type of opportunities we want to provide. The board wants to provide you doctors that have some issues. Guilty of offensive behavior. And if you've been found insane or incompetent, then yes, we need the board would like to visit with you. These cases that they go to the prosecutor to draft a verified complaint. The charges will be presented to the board. You'll receive a copy of the complaint. You'll receive a notice of appearance letter. Sometimes the question is, do I need an attorney? It's not for us to tell you, but if you're being charged in front of a board, it might be a good idea for you to obtain an attorney. This is the type of hearings that we have. They're not criminal. They're American Procedures Act. And in that, hearsay is allowable. Our prosecutor will be able to ask you questions. And our board members, which consists of 6 doctors and 2 lay people, they're considered judges, and they will also be allowed to ask questions of you. So it's a it's pretty intimidating to have to sit there if you ever get in that position and be able to answer questions of at least 9 people. So the board has a lot of leeway. They can go all the way from revocation all the way to suspension or multi-year suspension, or require you to do additional CMEs, prescribing courses, long-term treatment, and the doctor will absorb all these costs. These costs will be passed on. You'll have a time frame in which to do them. We also, as John and I are investigating cases, we're keeping time. So the board will also assess a reimbursement cost of the investigation for the board. So it is not cheap, and those costs need to be paid back within a year. We do have a plan, and we can make a payment plan because sometimes the investigative costs get pretty expensive. If you do get a board order, it is reported to the National Practitioners Data Bank and it stays with you forever. So that's why on the DUIs, we like to encourage you all to go to OHPP first. If you can resolve that through them, that's going to be much better for you. We also, depending on if you get a prescribing issue, there's a good possibility the board will say you can no longer prescribe CDS and that they will require you to surrender. If they don't require you to surrender, OBN and DEA will come to you and say, you can't write, so please relinquish your OBN DEA registration. Can you get them back? Yes, you can. If that's between you and OBN and DEA. If the board asks you not to prescribe for X amount of time, at some point during that time period, usually it's a 5-year period, they may allow you, we've seen it in the past, that they will start seeing if they can trust you again and allow you to start with maybe 4s and 5s. We've seen it in the past, not saying that will happen, but this is what we've seen in the past. Also all of the orders I send out to OBN and DEA, Oklahoma Healthcare Authority, any entity that might need to know the information on you about your order. Because if I don't send it, at some point they'll call us for it, so we just go ahead and send it out right away. That order is public record, so anybody can look at it. Of course, if you have an attorney, there's going to be legal fees. Unfortunately, if your ability to prescribe drugs is taken away, insurance companies may cancel you, hospitals may lose your privileges there. It's just a big catastrophic loss if you have a serious violation with the board. The bottom line is document. Here again, I'm going to say if you don't write it down, it didn't happen. So that documentation is history and physical, pain assessment, history, coexisting conditions. Just document their whole history. There are scammers out there. We talked about scammers yesterday in a talk early in the morning yesterday. There are patients that are scammers. I always tell them that if they can come in and pronounce the drug and spell it, then you probably ought to think twice and figure out if this is a real legitimate deal or if this is a scam. You all can protect yourselves by doing your proper guarding against drug diversion, doing all your lab work to see if they have those medications in their system that you prescribe them and they don't have any illegal stuff in their systems. And also, I will tell you, you are allowed to terminate patients. You have to document why you're terminating and if they violate your pain management contract. Here again, if they don't have the drugs in their system they're supposed to have that you prescribe them, or they have the illegal drugs, that's up to you, but that may be grounds for you to terminate. Make sure you write that in the letter, include that letter in their medical chart, and also make sure you give them an adequate supply of the drugs they're on, and also a list of doctors that might be able to treat them going forward. it matters about documentation, checking PMPs. You know, PMP is not required to be checked on every patient. I know a lot of physicians that every patient that comes in, every time they check a PMP, that way they're covered. Not necessary, you only have to check it the first time on those 5 particular drugs and every within 180 days after that. However, a lot of doctors have just chosen to check the PMP. And that PMP now can be included in their medical chart. So it's there for you to look at. Here's our contact information. If you need to get a hold of us. I'm going to cover a couple other cases that I've worked. I had a doctor when I first came on. He was working 11 days a month. He also was writing 186 scripts a day. There had days he would see over 100 patients a day. So he had 9 deaths associated with his practice, and the board was able to sanction him and take him away from prescribing for 5 years. We had a doctor who was self-medicating. She tested positive for meth. She was writing her boyfriend and his family prescriptions. She had written 265 prescriptions and only charted 9 of the prescriptions she wrote. And these people were driving 100 to 150 miles to fill the prescriptions just to get them out of the area. So she was suspended for a year, and then when she came back, she was on a 4-year probation. So pay attention to who you're prescribing to, make sure you document it, because it will protect you. We've dealt with disruptive doctors, and this disruption is sometimes against the patients, and in this case, it was against his supervisor and the company he was working for, and he started sending threatening emails to them. So he was sent away for some evaluation, and it helped him, and haven't had any issues with him since. We did have, before I came to the board, there was a doctor who wrote a prescription for 780 Xanax. And he told the board the reason he did was it's just easier to give him that many, so he wouldn't have to write all the scripts all the time. So needless to say, he got in trouble. We've had a couple of doctors late in their career take on like weight loss clinics, and it just so happens both doctors at both places got sick for a while and were out. Their assistants, medical assistants, thought it was a prime opportunity to help their friends and family, so they started giving prescriptions out to friends and family unbeknownst to the doctor. However, the doctor still got in trouble. I think one doctor got a $40,000 fine from DEA over that. We see occasionally the spate of supervised, because we've had some doctors supervising a mid-level 90 to 100 miles away. And so there's a lax of watching the charts and seeing what's going on a day-to-day basis. And this particular doctor just flat didn't check his PA for 6 months, and the PA was writing and actually forging his name on scripts. So the PA got, I think, arrested by OBN. Our doctor got a $25,000 fine from OBN, and he went to a CDS workshop up in Ohio. So it was expensive for him. Another doctor that we dealt with, at the time, DOs were allowed 2 mid-levels. This doctor had 7 mid-levels advertised on his website. And so we opened an investigation. And once we got into it and started checking the PMPs, we found that on one particular day that he had written 259 prescriptions to 9 patients, which what it amounted to was we went out one day to visit him and pick up some med records. he wasn't there, but his mid-levels were, so we visited with him. He had 3 mid-levels we visited with, and each one of the mid-levels had 25 scripts for each day for Thursday, Friday, and Monday, already signed, already dated by the doctor. So the doctor never saw those patients. These mid-levels were getting them out. So that's why, and when we pulled his work record, that's why we knew he had 9 patients that day, and then PMP showed he wrote 259 scripts that day, because he was signing and predating all the mid-levels scripts. So he got in some serious trouble. We did have one doctor who had licenses here in another state out west. He attempted to get on an airplane at an airport, and his bag was a loaded 9mm weapon, and his bag was full of loose pills. He was impaired at that point, and when he got to discussing it with the airport officials, he told the airport officials he was taking all those drugs back to get. He was the medical director of a county jail in eastern Oklahoma, and he said he's taken back to distribute them to the inmates. So, needless to say that another state was also looking at him. So the stuff he was supposed to do for the, like, writing policies for the other state, he never did. He never provided us copies of that. And so this doctor was revoked. He also lost his licenses in California, Nevada, and Utah. So there are some serious consequences with it. Some of our biggest investigations also deal with overprescribing deaths. And serious issues, because those get criminal. Eventually, some of these cases have gone criminally, and the doctors have been convicted and placed into incarceration. The DEA in the recent years has started cracking down a little bit more, and we've had a couple of doctors get convicted and do plea agreements with the DEA. A couple things happen out of that. They have to surrender all of their medical licenses for the rest of their life. They can never reapply for any medical license anywhere. And they also end up with some jail time and also serious fines of up to $1 to $2 million. So it is serious. It's a new era over the last 4 or 5 years. So they are, and you know, we still have cases out there being adjudicated by DEA at this point. I guess the bottom line is pay attention to what you're doing. Pay attention to who you're prescribing to. The other thing that I see in dealing with doctors that have been, that have received orders and come to us, once the doctor's placed on probation, John and I are usually their probation officer. We'll expect, you know, a monthly contact from you. You'll have a report to do every month. There'll be a maintenance fee in addition to what costs and fines you owe. And you'll be coming to see the board every quarter for a while. You know, if you, at least for the first year, then it may move to every 6 months. So that's kind of the way it happens. And we just, you know, urge you to pay attention to what you're doing. If you've got questions about prescribing, call us. If we don't have the answers, we've got 3,500 doctors that will be able to, that we can call and ask the question, try to get the correct answer. So, you have anything else, John? Is there any questions?
Mostly just things out of curiosity.
Okay.
Where did that go? I don't see any questions online.
Okay.
That makes sense.
We are, I will say, we are a board that we answer the phone, we talk to people. I know boards in other states, it's real hard to get into to visit with anybody. So feel free to call us. We'll try to get the answers. So, and if you've got additional questions that we may not be able to get to, please email us. You can email the you can contact us, you email us or call us, and we'll be glad to answer those questions, so.
I was gonna say, I know a lot of this centers around opioid
Yes.
med management. Do you ever get into stuff with like non-scheduled drugs, like medical management, Botox?
Botox is a big issue, Botox parties. What John answered this, you're a Botox guy.
Now, Botox isn't the only unscheduled drug that we have problems with. But Botox is in such a gray area that doctors don't know who's allowed to inject it or who's supposed to be there when they do. So we maybe get that once or twice a month, and we deal with it best we can.
You had mentioned earlier, like a scope of practice thing with, like, what was your phrasing specifically? Something to do with supervising outside of scope. Is that what you're referring to? Is that sort of thing?
Two different things.
Okay.
Supervising outside scope usually refers to mid-levels, which would be the LPRNs and the PAs. When it comes to Botox, they're letting LPNs, and the doctor's not even allowed to supervise an LPN as far as like they would at mid-level.
On the supervision, if you choose to be a supervising physician, a couple things you might ought to know. Number one, you should ask your mid-level, being a PA or RN, nurse practitioner, to provide you a document that says what their scope of practice is. So that way you know what their scope of practice is and you don't ask them to do something that's outside their scope of practice. That way, because you can say, go do this, and they're not supposed to do it, and if they do it, then not only in trouble with their board, then our doctor's in trouble because they asked an unqualified person to do a procedure or something that they shouldn't have. But if you want to do something and you're not quite sure, give us a call. We'll be glad to try to figure out and help you all out any way we can. And don't feel that if you call the board, you're going to get in trouble for asking a question. That's not our purpose. Our purpose is to help you all get through your practice and understand, and don't be fearful of asking a question of us because, and I'll tell you, we're not headhunters. We get assignments and we go out and find what we can find and move on to the next one. So, okay.
Kind of curious, what with the advent of medical marijuana in Oklahoma, have you all dealt with stuff with that?
We have, and the most part that we have dealt with is the way that doctors have left signed applications in a dispensary. So, and to me, I'm not really sure at this point whether he signed one and that dispensary copied them all off and left them there or not, but I don't believe that they can give those recommendations out in a dispensary. So I think it has to be, if they're going to do a recommendation, it has to be outside of a dispensary. Now, I believe that's right. I am not up on the OMMA laws at this point, so, but I think that may be at this point, can you think of any other issues come up?
Well, they have to have a doctor-patient relationship to recommend marijuana, so.
Right. And if you didn't hear that, it's like any other examination. It's called a application for the card. And you still have to, if you're going to sign those applications, you still have to have a doctor-patient relationship and maintain a medical record for it. Okay, just like you would any other patient, because they are patients, It's a recommendation for a card, not technically a prescription for it, okay? Okay.
Thanks for just ask for time, so thank you all.